Peripheral neuropathies or polyneuropathy represents an extremely common condition in neurology. And so we're going to go over the big picture of this. First of all, when we say peripheral neuropathy in general, the great majority have stocking glove features, which means distal, usually starting in the feet almost always, and then in the hands. And so in terms of sensory, this can either be a distal loss of pain and temperature, that would be by far most common, or if the large myelinated sensory nerve fibers are affected, then we can have a distal loss of vibration and proprioception. And in a severe peripheral neuropathy, let's say someone that's had diabetes for a period of time, there is initial involvement in pain and temperature, and then later on loss of vibration and proprioception. Over time, we'll have distal weakness and atrophy, and we'll see there are some neuropathies, minority, that have more weakness than sensory loss. Guillain-Barre would be a good example of that. Reflexes diminish in patients with peripheral neuropathy, and just like we have stocking glove sensory motor features, the most distal reflex, which is the Achilles reflex, is the one that drops out first in most patients. And we'll see there are some types of neuropathy, diabetes would certainly be the most common, that has prominent autonomic system involvement. So patients are prone to have orthostatic hypotension with syncopal episodes. That can affect autonomic control of the GI tract, and we can have gastroparesis and a number of other symptoms of autonomic dysfunction. So here's just a nice drawing showing you what we mean by stocking glove. So patients will generally say it starts in both toes at the same time, roughly, with numbness, and it works its way up, and then after a period of time, there's a similar feeling in the fingertips, and then moving up the arms. So here's a mnemonic that can be helpful to remember a number of different causes of peripheral neuropathy. So we can say dang therapist, or I guess dang the rapist, either way. And so diabetes here at the top, and I've underlined the ones we're going to talk about in a little more detail. The most common cause of neuropathy in the United States and throughout the world. Alcohol exposure, which is generally over a long period of time. And even if patients tell me they don't drink alcohol if they have numb toes, I'll ask if they used to drink alcohol in the past. And so if someone was an alcoholic for decades, they would still be much more likely to develop peripheral neuropathy even years after stopping alcohol. B12 deficiency would be our most common nutritional issue related to neuropathy. And this really presents more as a spinal cord syndrome, so we're going to say more about that when we get to spinal cord. Guillain-Barre we'll talk more about. Under trauma, I've put the entrapment neuropathies, so we'll talk about carpal tunnel syndrome and ulnar neuropathy and so on later on. There are a number of different hereditary neuropathies, but by far Charcot-Marie Tooth is the most common, so we'll say a little bit about that. In the endocrine category, hypothyroidism is the only one I'll mention here for the quick review. And so these patients come in complaining of numb toes, but you'd like to hear other things in the history that would suggest hypothyroidism. So maybe they have a cold intolerance, and maybe some hair loss and constipation and fatigue and dry skin and other things that would suggest that the neuropathy is really a manifestation of hypothyroidism. And that's always satisfying because you fix the hypothyroidism and the neuropathy gets better. Under rheumatologic, most of the neuropathies here that are associated with rheumatologic syndromes present as a mononeuritis multiplex. So in other words, it's part of a vasculitis where we have ischemia and individual nerves get picked off. So this category is very different. Patients have very asymmetrical symptoms. So maybe they have a right perineal neuropathy and a left median neuropathy. Okay, that's not your stocking glove presentation. So if we have a very multifocal, asymmetrical polyneuropathy, then we begin to think of this category. Amyloidosis, I won't say more about. This is a severe progressive peripheral neuropathy that has a lot of autonomic involvement, and usually these patients have a lot more going on than just neuropathy. They're fairly sick over time. They have heart failure and renal failure. And so if we have neuropathy kind of in that kind of a bigger picture of other things, then amyloid would be suggested. I'll talk about porphyria in a little more detail, not because we see it that often, but because it's a frequent board question. In the infectious category, we have HIV, which we'll come to in a later lecture, and leprosy would be another example here. Of course, something we don't see much in this country, and fortunately going down dramatically in the world. Sarcoidosis is the one on here that is just uncommon enough that I won't say any more about it. And then we have a number of toxins, so medications like phenytoin for seizures. If patients take that, particularly over decades, they can get peripheral neuropathy. If you prescribe INH for tuberculosis, you have to give vitamin B6 with it, or else patients may develop peripheral neuropathy. And also with regards to vitamin B6, if patients take mega doses of vitamin B6, this is actually toxic to the sensory dorsal root ganglion, which are responsible for the health of the large myelinated sensory nerve fibers. So these patients come in with a very distinctive syndrome of falling because they have a severe loss of vibration and proprioception sensation. All right, we'll say a little more about arsenic, lead, if this was helpful. Someone showed this at a conference I was at a number of years ago. Lead exposure, chronic lead exposure. So maybe we have someone who works in a gun shop or does a lot of soldering work. Some occupational exposures like working with batteries. So ask about someone's occupation. So lead neuropathy tends to present mainly with weakness more than sensory loss. And the radial nerve may be more involved in lead neuropathy. So Frankenstein, as he holds his arms up, he's got a finger drop and a wrist drop. And so that helps you remember lead toxicity. HIV medications, again, we'll come to in a later lecture. And I'll mention two chemotherapeutic medications, vincristine and cisplatinum. Vincristine, I definitely would remember because the mechanism is known. It affects the microtubules. Okay, so patients who are on that for a variety of different cancer syndromes will frequently develop neuropathy. But again, because that mechanism is known, I would try to remember that. And cisplatinum is the other cause of neuropathy I'll tell you about that is really a neuronopathy. So neuronopathy means the problem is with the dorsal root ganglion and hence the large myelinated fibers. So the two to remember are B6 toxicity and cisplatinum exposure. So patients, the presentation is not really, doctor, my toes are numb. It is falling. So you do your exam and they have a severe loss of proprioception and vibration. Okay, diabetes, you should know the mechanism. So it's really two things, and there's really more to it than this, but certainly part of it is vascular. So they have a diabetic microangiopathy, or we can call that an endoneural arterial hyalinization. But also the persistent hyperglycemia leads to some of the glucose to be converted to sorbitol, and that's harmful because it increases the osmolarity. We get some water influx, and that's harmful to peripheral nerves. Now, we don't do a nerve biopsy very often in patients with diabetes that have neuropathy because it's not much of a mystery in terms of why they have a peripheral neuropathy, so biopsy isn't needed. But if we were to do it, we'd see axon loss and we'd see some thickening of blood vessel walls in the perineurium. Guillain-Barre syndrome would probably be the most commonly asked peripheral neuropathy for board. So the other name is acute inflammatory demyelinating polyradiculoneuropathy. So it's acute. If you were to do a nerve biopsy, you'd see a lot of inflammation. The main mechanism for most Guillain-Barre is demyelination. And poly, of course, many, radiculo, which means nerve roots, and neuropathy, polyradiculoneuropathy. And so it's not just the peripheral nerves that are affected in Guillain-Barre syndrome. It goes all the way up to the nerve roots. In fact, the nerve roots may be the site of initial attack. All right, so Guillain-Barre many decades ago overtook polio as the most common cause of an acute flaccid paralysis. So, of course, you'll remember that patients have a preceding illness. in at least 2/3 of cases. And so this can be a variety of viral and bacteria. Campylobacter jejuni is the one you definitely want to remember. So that's usually a diarrheal type illness that then will be followed a week or two later by diffuse weakness. All right, so the initial symptoms are actually sensory in most cases with some numb toes, but the predominant feature is weakness. So this is an ascending paralysis. So botulism can be quite similar. Both patients come into the emergency room because of weakness that's rapidly progressive, but botulism is a descending paralysis. And remember that anything that is myelinated by Schwann cells can be affected in Guillain-Barre. So cranial nerves 3 through 12, all myelinated by Schwann cells, but in particular it's cranial nerve 7 that is affected. So it's usually a bilateral facial weakness. And so the big concern in patients with Guillain-Barre is respiratory failure. And so that's what we really need to monitor for, and that usually happens between weeks 1 to 2 of the onset of symptoms. Most patients, once they hit week 3 into it, turn the corner and begin to improve. Okay, so again, it's demyelinating, but yet a lot of autonomic involvement. So patients have irregular blood pressure, and they may have a variety of arrhythmias from the autonomic involvement. So how do we diagnose? You do a lumbar puncture, which reveals high protein, but nothing else. So it's not in inflammatory cells, but high protein. So we call that albuminocytologic dissociation. And actually the more helpful test is an EMG. And on nerve conduction studies, we see lots of conduction blocks. And so what is a conduction block? It's a focal area where there's loss of myelin. And that's exactly what happens in Guillain-Barre. Lots and lots of just focal demyelination. So again, we don't do a nerve biopsy very often, but you can see there that with the that we can, if we needed to stain for myelin here with the Luxol Fast Blue, we could pick out the demyelination. Now, sort of related to that is CIDP, so chronic inflammatory demyelinating polyradiculoneuropathy. And so this presents more slowly, and this is a chronic condition that patients need to be treated for, usually for the rest of their life. But think of just everything I told you about Guillain-Barre, and CIDP is the same, except it's over a chronic, long-term period of time. And so CIDP is the most common treatable neuropathy that is missed. And so you want to think about patients that have more of a motor neuropathy, not just the numb toes, but they're coming in because they're weak. And just like Guillain-Barre, they have no reflexes. Okay, and so that's sort of a motor neuropathy, no reflexes. They'll also have loss of vibration and proprioception, just like Guillain-Barre, because it's demyelinating. And so we need to diagnose this with EMG, lumbar puncture, just like we do for Guillain-Barre. And Guillain-Barre responds great to IVIG and plasmapheresis, or PLEX. One difference here is that CIDP also responds very well to prednisone. Okay, steroids do not help for Guillain-Barre, but they work well for CIDP. All right, there's a variant of Guillain-Barre called the Miller-Fisher variant. The time frame is just like Guillain-Barre, so it hits hard, and then they turn the corner after about 3 or 4 weeks. But in this case, we have a significant eye movement problem. So remember, ophthalmoplegia is just a big word for a severe eye movement issue. And so usually this is quite profound. Patients may lose eye movements altogether, may have severe ptosis. They have areflexia, just like patients with Guillain-Barre, and usually they have ataxia. And so in Guillain-Barre and CIDP, we don't have an antibody, but for the Miller-Fisher variant, we do. So anti-GQ1B antibodies, very specific, sensitive, so we can confirm here the diagnosis. And these patients usually have a good recovery. All right, and just to kind of insert here, boards will often ask you to distinguish between central and peripheral demyelinating conditions. So remember Guillain-Barre, of course, Schwann cells. So it's the peripheral nervous system, cranial nerves 3 through 12. MS, of course, oligodendrocytes, but now it's the central nervous system, and don't forget cranial nerve too. So when we talk about multiple sclerosis, of course, the optic nerve is prominently involved. And then just as a big picture, don't forget that oligodendrocytes myelinate multiple axons, in contrast to Schwann cells, which have a one-to-one relationship. All right, a couple here I'm going to mention just because they're high yield for boards. So I've only seen 2 patients with arsenic neuropathy in 20-some years, but yet this often comes up. And so think of arsenic either occurring as an acute high-dose exposure, and if that's the case, it looks like Guillain-Barre syndrome. They're coming in very weak. One distinguishing feature is they have a lot of GI symptoms, which I didn't mention with Guillain-Barre. So that's not really seen in Guillain-Barre, but might suggest more of an arsenic poisoning. If someone has chronic exposure, and I think you would usually get a story of chronic well water use for drinking water, then it's not like Guillain-Barre. It's more like your, numb toes, stocking glove kind of a presentation. And here we may see Mies lines with a chronic exposure. All right, these hypopigmented areas in the nail beds. And of course, there's a differential for Mies lines, but this is the one that relates to neurology that you need to know. So again, chronic exposure, it's more of a sensory peripheral neuropathy, just numb toes. Now, of the hereditary neuropathies, Charcot-Marie tooth or hereditary motor sensory neuropathy, and there are different types, make up about 2/3 of these. These are usually autosomal dominant. And so on chromosome 17, we have the peripheral myelin protein gene. And so here we either have a duplication or a point mutation of this PMP22 gene. So we can confirm most cases of Charcot-Marie tooth through genetics testing. So these are more of a motor neuropathy, slowly progressive weakness, atrophy. So these patients end up with usually significant foot drop and atrophy below the knees, and then later involving the hands. So this is early onset, and usually not much of a mystery because there are other family members that have it, and so the diagnosis is usually pretty easy. Okay, when we have a chronic neuropathy that involves the motor nerves predominantly, then we often have a lot of disfigurement. So very high arches, and over time the toes pull back like this. We call these hammer toes. And here's a patient with Charcot-Marie tooth, and we can see just the tendons here because of the very severe atrophy. All right, so we can diagnose by genetics testing. If you have someone, no family history, or maybe they're adopted or something like that, we'll often do an EMG in that case. And since these are demyelinating, and myelin is important for speed of conduction, we have an extremely low nerve conduction velocities in patients with Charcot-Marie tooth. Again, another one I mentioned primarily for sake of boards, and that is acute intermittent porphyria. So as the name indicates, this comes on acutely, sort of like Guillain-Barre. And so we know these are due to porphobilinogen deaminase deficiency, and so they present with these severe attacks like Guillain-Barre. Like Guillain-Barre can involve cranial nerves and even respiratory failure. So a lot of overlap there. But these patients have a lot of abdominal pain. And so again, arsenic kind of looks like Guillain-Barre. They also have a lot of GI symptoms. So that would maybe point you away from Guillain-Barre. Significant autonomic involvement like Guillain-Barre. But an attack of porphyria usually involves the brain. And so these patients are often confused, may have seizures. And so the brain's unaffected in Guillain-Barre. And so that would be another distinguishing feature. And I think what would really jump out at you on a board question is that these episodes are triggered by something. And so most often sulfonamide, antibiotics, maybe barbiturates, some other medications. So patients put on a new medication and then has an attack of weakness. Now you should be primed to think of porphyria. So we can diagnose this by doing a urine porphobilinogen test. And there's some things we can do in the hospital, but I don't think that's, you'll be asked that on boards. Now, something that is just practical is that about 1/3 of patients, and so these are kind of non-diabetic patients coming in with numb toes, you're not going to find the cause. So we call that idiopathic sensory polyneuropathy, and it tends to be small fiber, so it's mainly pain and temperature. And although this is uncomfortable and often painful, the prognosis is good. And so we see this mainly in the elderly, and we treat the symptoms of pain, but these patients have a good prognosis in terms of being able to remain on their feet. Just a word about a focal neuropathy here, herpes zoster. So, of course, most people have been infected here with the varicella zoster and have this infection, sort of latent infection, hanging out in the sensory ganglia. And so it can be reactivated in certain situations. Not always, sometimes it's just normal people, but if we have someone immunosuppressed or going through some stressful medical problem, then they're more likely to have reactivation. And so I'll show you a couple of pictures here. What we usually deal with in neurology is that this is very painful. So after the shingles, the vesicles go away, they have just a horrible pain in the distribution, whatever dermatome was affected. And we call that post-herpetic neuralgia. And so we can have roots involved. So here are a couple thoracic dermatomes here with shingles, and cranial nerves can be involved. Here is a V1 shingles affecting that ganglia. All right, so just a summary. What are some acute peripheral neuropathies? So Guillain-Barre, acute intermittent porphyria, and acute arsenic poisoning. Okay, so again, porphyria, think about medications triggering that. They have brain involvement as well. And arsenic, they're going to have a lot of GI symptoms, which you wouldn't see in someone with Guillain-Barre. Most peripheral neuropathies, by far, are more sensory than motor. But the ones that are more motor with more weakness would be Guillain-Barre and CIDP, Charcot-Marie-Tooth, acute arsenic poisoning, acute intermittent porphyria, and lead toxicity. Remember with that radial neuropathy. The two neuropathies that affect the dorsal root ganglion and therefore affect sensory nerve myelin, so we call that a neuronopathy, are B6 toxicity and the chemotherapy cisplatinum. So again, falling because they don't have proprioception sensation. What affects large myelinated fibers? Guillain-Barre and CIDP. So remember, it's more of a vibration proprioception loss. We don't call this a neuronopathy because it's not just the sensory nerves. They have motor involvement as well. Hereditary, Charcot-Marie-Tooth is the only one that I'm going to talk about. So strong family history, then you'd want to go for that diagnosis. And autonomic involvement, diabetes. I mentioned prominent autonomic involvement. Guillain-Barre, lots of autonomic involvement, and acute intermittent porphyria. Now let's finish up just talking a little bit about the entrapment neuropathies. So three common ones in the upper extremity, one in the lower extremity. So carpal tunnel syndrome, of course, extremely common, related to overuse of the hands. And so patients, the problem is median neuropathy at the wrist. And so patients come in complaining of a numb hand. And remember, what you want to hear is that it wakes me up from sleep at night. So nocturnal awakening. Carpal tunnel is by far the most common cause of a numb hand. And so most every patient will just say their whole hand is numb. And so you want to ask them, well, if you had to say which finger is the most numb, you know, if they said the index finger or the thumb, then that would be consistent with carpal tunnel. I've rarely ever seen someone that is able to notice that it, you know, splits the fourth finger. But we can do some pinprick testing and see if we can, you know, confirm that. A muscle that may be weak in carpal tunnel is the abductor pollicis brevis. So notice the normal muscle over here, and can you see the atrophy right there? So look carefully at the hands in carpal tunnel syndrome. I won't talk about the Phelan's and Tinel's testing. Neurologists don't typically do these because the specificity and sensitivity is not very good. So if we do nerve conduction studies, we'll find a prolonged distal latency. So if we stimulate the median nerve at the wrist, it takes longer for that impulse to cross through the carpal tunnel. So these patients respond very well to surgery, a carpal tunnel release done by an orthopedic hand surgeon. Remember also during pregnancy, because of some hand swelling, this is common. We're not going to operate in that situation because that's going to resolve after delivery. But a wrist splint at night can help because it tends to keep the wrist straight. Now, ulnar neuropathy is more of a motor than a sensory problem. And so the ulnar nerve supplies so many muscles in the hand that these patients complain of hand weakness. It's frequently due to elbow resting. So in particular, if someone is sitting in a wheelchair, they're resting on their elbows all the time, then they will develop some hand weakness. And of course, if you get numbness in the fourth and fifth digits, then that would be quite suggestive of ulnar neuropathy. And so usually the mechanism here is conduction block at the elbow, in which case the prognosis is really good. They avoid elbow resting and the nerve can remyelinate. And over time, I should just mention, it can develop this claw hand deformity, which here is quite typical for ulnar neuropathy. Now, radial neuropathies, usual story here is the Saturday night palsy, where an alcoholic falls asleep with arm resting over a chair, and so then they wake up with a finger and wrist drop. And so the extensors are affected at the wrist and fingers, but triceps for elbow extension is spared because the nerve to triceps, even though it's radial, but comes off before the spiral groove. Okay, if the lesion is higher up, and this term honeymooner's palsy is used in various ways, so I wouldn't make too much of that term, but if the spouse sleeps in the axilla or there's some problem with the radial nerve above the spiral groove, then the triceps will be weak. And just remember, I put lead toxicity here. I put question mark because it's not that highly associated with lead, but for boards it might be. So remember, lead tends to involve the radial nerve. And here's just a nice drawing of the radial nerve. All of these extensor muscles, well, not all of them are extensors. The brachioradialis is an elbow flexor, but here is the nerve to triceps. And so just notice that the spiral groove here, if our lesion is right there, the triceps will be normal. A quick word about axillary neuropathy. So this is often related to shoulder dislocation. And so in this case, we can see a normal deltoid over here, some atrophy over here, and these patients will have a patch of numbness here in an axillary neuropathy. So it's just a nice slide to show you some sensory distributions here of the radial nerve back of the arm and hand involving digits 1, 2, and 3. There's the median nerve and then the ulnar nerve. Okay, and we'll finish up with perineal neuropathy. Now, as the perineal nerve comes off of the sciatic here, remember the sciatic is just the perineal, or fibular it's now called, and tibial nerves bound together. But as these branch off here, we have the common perineal or common fibular nerve, and then we have a deep branch. And this supplies tibialis anterior, which is dorsiflexes the foot, and also supplies muscles down here in the foot that extend or dorsiflex the toes, like the extensor digitorum longus, extensor hallucis longus. And so if our lesion is of the deep branch, then the patient will have weakness with dorsiflexion and some numbness between the first and second toes. Now, we also have a superficial fibular nerve here, maybe better seen here, which supplies the peroneus longus and peroneus brevis. So these are important for eversion of the foot. And so if we were to have a selective lesion here of the superficial peroneal nerve, then now we would have a problem with eversion, and the numbness would be involving the lateral ankle and the dorsum of the foot, but notice sparing between the first and second toes. All right, now, what if we have a lesion all the way up here, proximal here in the common fibular nerve, and so the perineal nerve or fibular nerve is very superficial here. So the mechanism is often prolonged leg crossing. And so if we have our lesion up here, well, now the patient is going to have a foot drop, and they're going to also have weakness with eversion of the foot. Again, here's peroneus longus. And now the numbness is going to involve the lateral ankle, top of the foot, and between the first and second toes. So when we have someone with foot drop, most common cause is a fibular neuropathy. All right, and so they're going to have weakness with dorsiflexion, of course. If the superficial peroneal nerve is involved, so maybe the lesion is proximal of the common fibular nerve, they're going to have weakness with eversion. And so usually the most helpful muscle to check in a foot drop is inversion of the foot. All right, because this is an L5 muscle supplied by the tibial nerve, and the second most common cause of a foot drop is an L5 radiculopathy. So if we have an L5 radiculopathy, weakness of inversion will be seen. So this inversion is not supplied, this is posterior tibialis, not supplied by the fibular nerve. And so if we have weakness there, then we know we've got to move the lesion more proximal. It can't be fibular nerve. And most likely it's going to be of L5 nerve root. Plantar flexion, of course, is S1, S2 tibial. All right, so as we go through the review here, I think there are 5 causes of foot drop you should know. And so peroneal neuropathy or fibular neuropathy is most common. Peripheral neuropathy, I mean, you're a patient with diabetes, they're usually going to have a bilateral foot drop, right, with stocking glove sensory loss. Okay, and then we'll come to these other 2 here in subsequent lectures, L5 radiculopathy and ALS, and we've already talked about myotonic dystrophy, which, recall, is a muscle disease, but it's unique in that patients have distal weakness. Okay, we'll stop there.